To welcome everyone to today's event and thank SVIN for organizing today's talks.
On larger scale data remain very limited in terms of how COVID-19 has a relationship with stroke and other neurological disorders. So when it comes down to expertise, I think everybody provides different expertise, and depending on the source and experience in terms of clinical as well as other exposure. I will speak about specific or detailed causal associations with neurological sequelae that are known in COVID-19. Talk about the relevance of stroke and neurovascular disorders. There are a lot of vascular correlates here as well. And then talk about what I say from a tongue-in-cheek standpoint, what are the complications in neurology? So not just neurological complications that we started to hear about 6 weeks ago, but complications in the field of neurology in terms of what we normally do, in terms of our normal care paradigms, the way we've implemented care, whether it's in terms of stroke systems of care, teleneurology, surge planning, which now we may say is a lesser concern, but still one that remains in terms of future waves of this pandemic, and some ethical dilemmas that we face in terms of how we deliver care, who we are treating and who we're not treating, and how it impacts stroke in a larger scope. So coronavirus is an entity that we are extremely well familiar with now, but have been exposed to it in the past. Within the last generation of people that have been practicing in our field, we remember quite well SARS and then MERS as well, both as well as this coronavirus, this COVID-19 pandemic associated with what is referred to as an ILI, an influenza-like illness with secondary systemic effects. And I remember from a personal standpoint, a couple of times in the last 20 years, we're actually looked into the literature on coronaviruses in general, because we had a couple of coronavirus cases that were quite severe in younger individuals with stroke. And what I found at the time was some of the data that we now know of COVID-19. Similar features of a severe systemic reaction, immune reaction, cytokine storm was alluded to, coagulopathy with larger vessel intravascular thrombosis, but then more recently, what's been raised is this neuroinvasive potential. But the PubMed chart below shows how many publications, and it's a little bit hard to see in terms of numbers, exist with between coronavirus and stroke. And literally it's handfuls of papers and years in between where there's nothing that relates the two. One should keep in mind that, coronaviruses, as you know, are extremely common. The human cold virus is a coronavirus. And then in terms of impact and as it's spread, everybody's been looking at charts of how COVID-19 has been affecting different regions, and the counts, the very morbid counts of both infected patients or individuals as well as deaths. And these are from a couple of weeks ago in LA. And as I point out, within Los Angeles County, that number is getting close to 4 times that over the last couple of weeks. So stroke and neurological care have definitely been on the front lines, both because this is what we would expect, possibly from the pathogenesis, as well as when we talk about patients presenting with severe, in severe states with potential neurological involvement. Stroke and neurological care are subdisciplines that would be expected to see the greatest impact. There are 2 features that I think themes that were present from early on in as this pandemic broke. One was to maximize resources. So we heard a lot about how do we protect our personnel, how do we maximize our use of individual expertise, how do we maximize our use of PPE of various kinds, ICU. There's a lot of focus on ventilator use, as well as ECMO capabilities, counting ventilators and what would be needed in different regions. And at the same time, the goal of minimizing exposure. So obviously, of trying to avoid contamination. As you know, part of the greatest difficulty with this outbreak was the fact that nobody knew for sure exactly how it was being spread. The very early reports came out a while ago now, suggesting that specific door handles and elevator buttons in the mall in Wuhan were a source of transmission. People have suggested that this is clearly an airborne mechanism may be at play, and not just airborne, but during specific types of activities as minimal as breathing and talking with an individual. Actually, the most interesting work on this, or there are some MIT studies looking very recently at what happens with and without various types of masks as well in terms of aerosol spread. And I believe it was just in the last couple of days, reports from the New York Times that they are still finding aerosolized signatures of the coronavirus in Wuhan, despite the fact that the pandemic is clinically gone down. Ethical considerations here came up along the way, and some perhaps not of the most grave as it relate to surge planning, but some in that regard were very blunt, difficult debates about how we treat patients with severe neurological disorders such as stroke. And I'll talk about that as well. But overall, the data that we have been relying on has not been what we normally expect. The vast majority of our data, believe it or not, and as you know now, derive from emails, texts of accounts from one location to the next, WeChat accounts because of so much of the early history of this pandemic in China. There was a very active communication means, WhatsApp channels and threads. I was involved with WeChats and WhatsApp and social media threads that overlapped. It was truly dizzying as these early reports came out. And then, of course, webinars and virtual meetings such as this, and everybody and every association or group seemed to come out with different statements on COVID-19. As well as online resource centers, supplemental grants, and COVID registries. Multiple COVID-19 registries were initiated. And then this overwhelming tsunami of research initiatives that has the good and the bad of it, because the good of it was the fact that there was a lot of research being done in various aspects in terms of prevention and of transmission, as well as treatment, specific treatments for complications, but also the bewildering aspect of figuring out how to organize clinical trials in this area, and a number of universities have been overwhelmed by how to organize this. So, a lot of this started with neuroses, concerns, anxieties about the disorder and the impact. And perhaps some of this is almost logical in terms of why it evolved, because we had very specific singular definitions as to who is positive and who is negative, who perhaps may be symptomatic or asymptomatic carriers, this concept of super spreaders, and then this whole question of antibody status. And I should comment that even at this moment, there remains a question after that antibody status as it relates to clinical impact. The question has been raised in the last couple of days and weeks as to whether antibody status really protects or not from subsequent reinfection. So a lot of anxiety, as you can imagine, because these definitions, without complete testing and even with testing, don't answer all the questions. The modes of transmission, as mentioned, all possible, much unknown. Even the suggestion that the coronavirus COVID-19 disease could be spread by tracking of shoes, and this has led a lot of people to be changing as they enter the house or other spaces or when they leave the hospital. Social distancing and PPE, of course, has been these have been pillars of what we've done in terms of reacting to and prioritizing care for during this period. but the relative effectiveness, compliance, and public health impacts have been unfortunately very interesting, especially as it relates to ethical issues. It relates to public health impact versus individual status, how we handle things based on things affecting one individual versus the larger public, that are big questions that remain as we now seek to reopen it in multiple places around the country. And around the world. We had some personal experience with this early on. The Frontiers case report up in the upper left that Purya published with our group is from the middle of March. This is one of the first stroke cases, we saw at UCLA, a large vessel occlusion and a left MCA stroke, where we went straight to MRI for potential thrombectomy. There was much discussion amongst societies, including with the neuroanesthesiologist, and Rado Rechev was instrumental in helping get involved from a SFIN standpoint in terms of working together with neuroanesthesiologists. And then Tan's paper and the SFIN statement that is being released in Stroke today as we speak. This evolved over a period of time and ramped up. There was even a difference in terms of the way this came about in terms of online publications from the more informal descriptions that existed before that I mentioned, to then the full papers. So as a great example, the paper shown here, which is one of the main papers that chronicled both central as well as peripheral nervous system involvement, only came out actually in print recently, but a lot of the data was released earlier. An interesting, curious aspect of this was the relationship between strokes and the chest CT findings, and I actually had the experience of seeing some of these chest CT findings very early on as these cases were taking place in China, it has remained a question in terms of the role of chest CT as a diagnostic algorithm when we're treating people from a neurological standpoint. So COVID-19 neurological complications, this has increased a lot in the last several weeks. Early on, there were almost alerts or potential reports of potential complications and case examples, with a link being made to the ACE2 receptor, that the spike protein on the coronavirus had a specificity for ACE2, and this may be a link with endothelial expression that may lead to direct consequences in terms of the neuroinvasive potential from a vascular standpoint, and encephalitis as well. This, as you can imagine, had a lot of concern raised fairly early on about various medications, antihypertensives such as ACE inhibitors, that may affect the likelihood for one to get or come down with COVID-19 as a disease from a clinical syndrome versus others. The various neurological manifestations are listed in this table. So Avindra Nath, Dr. Nath from NIH has a number of different reports early on listing the various types of manifestations that may occur. So a viral meningitis, as one may expect, anosmia as an early symptom. Most people don't present necessarily with a chief complaint only of anosmia, as you can imagine. Others with much more fulminant encephalitides and what you may expect in terms of immune post-infectious immune manifestations in various parts of the neurological system as well. And there was a lot of concern about the possibility for hemorrhage as well and how that may play out. So this is another publication from online about acute neurological complications with the listings shown on the left, both as para or infectious as well as post-infectious syndromes, and then the list, a very long list of antiviral agents some with logical links and some with illogical links or unknown links to how it may combat the disorder. There were also actually about a month ago some very interesting reports about differences in terms of transmission in Eastern Europe and people with BCG vaccination earlier in life, and how that maybe have a differential propensity for disease. And I believe that there was a vaccine trial being studied in Germany, at least as of several weeks ago. So direct invasion was raised early on by this paper from Asia. The potential for direct neuroinvasive route. There's also this very interesting phenomenon from a systemic standpoint of the failure to react to the hypoxia. It was suggested that patients, for some reason, don't have the same reaction to the hypoxia associated with COVID-19 as one would normally expect if your saturation numbers drop to the 50s and 60s in terms of percentages. Some very, very low numbers, and that was used as a possible explanation as to why people were presenting so acutely, severely ill all of a sudden, and that the hypoxia was not recognized. Some suggestion that maybe this is a neurological correlate as well. Mitch Elkin gave a great presentation that I borrowed this from on the links between COVID-19 and not just stroke, but cardiovascular disease. As mentioned, the vascular link is clear. And I should say that it's probably not that much of a surprise in the sense that immune mechanisms commonly act through the vascular system in various circulatory beds. And a lot of the most severe patients we've seen with COVID-19 and others have manifestations, not just in the cerebral circulation, but in the renal and peripheral as well as coronary circulations. Some of the earliest reports actually suggest that a myocarditis of the smaller vessels in the heart may be at play when it comes down to myocardial ischemia or infarction. So increased risk factors and comorbidities are clearly a factor. Age is clearly a factor. Older age being worse, of course. The possibility of impaired immunity being an issue. Decreased physiological reserve that may be a little bit more difficult to quantify. The role of the ACE2 receptor as well as many other mechanisms that have been suggested. So the earliest reports on stroke came from within these Chinese studies where in studies on the order of about 200 patients, there were this number of about 12 plus minus stroke cases, and stroke cases of various types. So as you can imagine, if you do the numbers, this comes out to about a 6% rate in terms of neurological complications. But the nature of the strokes is different as well. Now these are all, if you look at the middle, one of the middle columns and to the right, these are all severe strokes, and severe COVID-19 presentations. These are people that were very, very ill. And if you look at the ages there, these are not young individuals. That story has changed a little bit with differences in terms of detection, both in terms of COVID-19 as well as in terms of just being on the lookout for how the complications may develop. We've seen a number of stroke cases in COVID positive patients stretching back, as I mentioned, now 6 to 7 weeks. Probably one of the most curious things was what our colleagues, what Mark Rebo presented from Spain, as well as the reports coming out of Italy and other places, as well as New York, actually, in terms of the timing that both Jay Mako and Joanna have relayed in terms of the timing. It was almost uncanny in terms of when it occurred in the middle of March. That was around the same time that we started to see cases within days, all within days of each other. Those were all different and delayed compared to the Chinese presentation of the disease. So the mechanisms were, questioned: endothelial damage, of vasculitis, as alluded to, differences in terms of cerebral edema, perhaps hyperemia, neurodegeneration. I would say that nothing has been left off this menu in terms of potential mechanisms. Critical illness myopathies, increased thrombosis, and hypoperfusion, as you can imagine. Part of the most difficult thing about the COVID-19 pandemic in the stroke world has been how to untangle this issue about who has COVID-19 related stroke that is causally related versus who may simply be infected or has been exposed to the virus and has stroke of other causes, or the two simply coexist. And that has been very difficult to really tease out. This other correspondence, one of the earliest correspondences in the New England Journal relating to the neurological features, is now, I should say, I hesitate to say, but old data, and there's a lot more. Thankfully, the New England Journal and other journals have made such data readily available so that we can communicate about these manifestations. A very early example of this was the role of antiphospholipid antibodies in this coagulopathy that was highlighted in this report in the New England Journal. And then the suggestion in the report of how intravenous or systemic TPA was being used around the clock for pulmonary manifestations. So the thought being that, the severe respiratory compromise and the lack of response on ventilator treatment after intubation was thought that may have been due to the vascular correlates that have less to do with the airway than to do with the vascular clearance and coagulopathy at various levels in the pulmonary circulation. This raised the question of the limits of invasive ventilation that may have been futile in some cases, as well as highlighted the role of ECMO in other patients. So COVID encephalitis was cited in these early reports, now only a couple of months old, but in locations that you may target from or may suspect have more immune correlates. So in terms of the complications in neurology, I think the complications have been almost greater than the actual neurological complications, perhaps. So as you know, almost the entire world canceled elective admissions and procedures. This is started to be lifted in various locations here in the United States now at different rates. This definition about what is emergent or what is essential care has been incredibly difficult to define. So, some have argued that, that the reopening of tattoo parlors is an essential service, and everybody has been championing or arguing for or against what is essential, who's not essential. But from a medical standpoint, this becomes very difficult. One can imagine that, we shouldn't be seeing emergent cases or essential cases that need to be seen within 24 hours in an outpatient stroke clinic, and that these belong in the emergency room or emergency department. But that has also led to probably one of the greatest impacts that, those with milder symptoms may have been avoiding hospitalization. And I don't think anybody has not seen this. I think everybody has seen the fact that the cases that we see in-house have been much more severely ill patients. And now we're just starting to learn about the sort of the delayed events that may have occurred actually in the last several weeks and months. So there are severe limitations that were in place in terms of diagnostic imaging. So MRI, as we rushed to in that early case of large vessel occlusion, it causes complications. It caused us a 3-hour delay in terms of cleaning the machine to be used by anybody else. This impacted electrophysiology, including EEG use, angiography, a lot of questions about how to prep the room, and this came out in the SFIN statement. The use of TEE, of transesophageal echocardiography, was largely banned at a lot of places, and this is a mainstay of our workup in stroke. Avoidance of immunosuppression consideration. So I remember very early on a couple of months ago, seeing for the first time a patient with potential CNS vasculitis and struggling with this issue as to whether I would reasonably refer this patient in for treatment, not just diagnostic evaluation, but relatively urgent immunosuppressive treatment for the vasculitis, given the nature of the outbreak of this pandemic. And then reconsideration of network care models, that we are clearly doing things very differently than we did in the past, specifically as it relates to telemedicine. There was this very interesting article by Zeke Emanuel, now a few weeks old, 2 weeks old, about whether this year is a year that will change the face of medicine forever, and whether this is a year that medicine is saved by being refreshed or revolutionized. So we have yet to see whether that comes true or not. All we know at the moment is that things have really changed in terms of care. So telemedicine has been a huge part of this, both in various forms in terms of the telephone, as well as telemedicine, televideo consultation, from pre-hospital side, emergency room, all the way through every phase of the hospital, as well as you can imagine, for transitional care and video visits for both new and follow-up consultations. What I've found is that where it can be used, everybody involved, patients, providers, and everybody else love it. And it does provide the same level of quality of care. And I think it's going to be very difficult to argue how the traditional methods do not. In terms of triage and management, different pathways and our approach to triage and care, there were a number of things put out. This is the Calgary group, and I should say the Canadian the collaborative statement that came out in the Stroke Journal a few weeks ago now, related to a protected code stroke, but also a number of things that came out about how we should manage patients either presenting with certain clinical features or with specific needs, such as difficult extubation or the process of intubation and extubation as they relate to acute treatment of stroke. So strategies in neurology. This is, I can't think of, this is a very widespread, there was a pandemic of publications on how COVID-19 was going to impact every single aspect of neurologic care. There were institutional, both proclamations, statements, planning, descriptions, policies that were put out, as well as in experiences in different areas, as well as in different subspecialties. How is COVID-19 going to affect neuromuscular disorders? How is COVID-19 going to affect epilepsy, as well as in far beyond stroke and neurocritical care? So in terms of neurological monitoring, there were these reports that were very interesting in terms of surveillance. So telemedicine with via continuous EEG and portable MRI. Perhaps a leap to the future now, or being catapulted to the future very rapidly. Complications in neurology also in terms of how it impacted care. Every single registry out there, and there's so many overlapping registries. And I should point out that we do have a SFIN COVID-19 registry that I hope that people will participate in as well, looking at this year versus last year. And you see the data shown from Shanwu Hospital, presented on their early SNIS webinar from that slide, showing the difference in terms of the radical decrease in numbers of cases of various types, looking at the exact same dates. And thankfully, we've had a voice amongst neurologists and vascular neurologists in the larger medical field, as well as in the public, about how hospital admissions may have been affected. And a lot of campaigns, including by the World Stroke Organization, SFIN and others, to encourage people to come to hospital when having symptoms of stroke. To not delay care, because many people have been afraid. So from an ethical standpoint, we've had a limited, we've had several limitations. There's a limited ability of severely affected patients to represent themselves, to provide clear and cogent and obvious histories. We've had difficulties in terms of resource allocation, specifically as it related to surge planning. I would note that at UCLA, we had, multiple evenings of teleconferences for hours on end as to how to define the degree of neurological impairment and what is a severe stroke and neurological catastrophes that may limit us at subsequent stages of surge planning where ventilators may be limited. And a lot of questions, a tremendous focus amongst all of critical care focused on the neurological impact and stroke. So surge planning, this is part of the plans that were developed. These were the finalized plans that were now developed more than a month ago. And as noted, catastrophic, as you see on the right, catastrophic irreversible neurological injury being a big category of disease, as well as trauma. But when you look at the terminology of what is catastrophic and irreversible in neurological injuries due to stroke, we have to be very careful about that in terms of, people have severe strokes in terms of deficits when they present. That doesn't mean that it's necessarily irreversible. And depending on which patients we're treating, that may vary based on age and other comorbidities. So a critical piece of this from an ethical standpoint has been disparities of care and avoidance of discrimination in any way possible, whether it means, in one facility or patient population to the next. And a big challenge that I should say, thankfully, we have not seen very much of, except that we are acutely aware of making sure that we don't discriminate. What we do normally for stroke, based around the fear or the other impact related to COVID-19. And I think that this still exists as a very active issue where we have to be careful, that there's no prohibition against giving TPA or going to thrombectomy simply because somebody may have COVID-19 or maybe a person under investigation or at high suspicion. We should do what we normally do, except with different approaches, with maximizing use of PPE and minimizing our exposure. So I concluded, and I conclude with this, that everybody's waiting for this, and it's a bit of a rhetorical piece or note that we don't have the conclusions. In fact, the conclusions have yet to be written, and we don't even know if we're going to have a second or a third wave that occurred with the 1918 Spanish flu pandemic, and there's a lot of concern about that. And how do we adjust to what's to come? I will. With tongue-in-cheek approach, say that I was very proud to see, and that I actually made this comment before the New Yorker article highlighted this, that the strokes, the name of the group that's been around for a while, but obviously related to our field, have been at the cutting edge when they defined earlier in this year the new album entitled "The New Abnormal" and where we would be going. And talking about and singing about this pandemic, and suggesting that this may be an alternative pathway for not just 2020 but beyond. So I'm going to end there, and hopefully we have plenty of time for questions and answers and debate or discussion. Tom?
Thank you for that very insightful presentation and a wealth of information. The first question that comes up, David, is that in the era of COVID-19, we're seeing both an increased number of stroke mimics, patients that come in with COVID that look like they're having a stroke, actually come in as a stroke code, but in fact are not a stroke. We're also seeing atypical strokes, such as potentially increased LVOs in our younger patients. So the nature of stroke is changing somewhat in our EDs. What are you doing to tell your physicians in the emergency room from an educational standpoint about what they should be looking for in our potential stroke patients in the era of COVID-19?
I think that it doesn't change necessarily in terms of what people should be looking for. I think that we have two types of cases, as you mentioned or alluded to. One is the much more directly related, severely affected patients where there may be strokes of increased severity and of different nature or subtype. So there, I would say that there is a subtype that I've seen that we saw. And then we have reports from other places of with multi-circulatory bed, large vessel thrombosis in unusual locations in people that wouldn't otherwise be expected to have this. So young patients that present with a CCA thrombosis with a clot extending all the way from the common carotid artery all the way up to the middle cerebral artery. Large vessel thromboses like that. That is something that is a particular manifestation that we're seeing. In terms of the counterpart to that, in terms of what other features may we be seeing, very difficult in terms of filtering out this issue of COVID positivity in people that are presenting with stroke symptoms. What we saw early on actually were intracranial stenosis cases of patients that had acute ischemia coming from the nursing home, people that had been recently discharged with stroke, may have had a new event. One of the difficulties that we actually had in that regard, and it gets into the specifics of the imaging approach, is that we shied away a little bit where we started to use MRI more sparingly. And a multimodal CT diagnosis of acute ischemia in somebody with an intracranial stenosis with acute on chronic ischemia, that can be a very difficult diagnosis to make, and so you're kind of left in between addressing both, addressing the stroke issues as they present and addressing their positivity or not, and assuming that everybody's positive.
The second question that comes up is, do you recommend full anticoagulation for all COVID patients with high D-dimers? If so, what D-dimer level? What are you doing at UCLA? Has this come up?
It has come up, and it came up very early. The thought being, as I mentioned, that if there's antiphospholipid antibodies, as well as, there was as I mentioned, this use of systemic TPA, what could be done? And I think that we are doing what is done in the most severe cases, which is, when somebody has a fulminant coagulopathy, we may consider the anticoagulation. The difficulty is that there's a hemorrhagic risk associated with these severe stroke patients as well. So balancing that against the risk of hemorrhagic conversion is very, very difficult. Is very, very tough. So I would argue that if we found a patient that had pure, limited degree and severity of ischemia, but was clearly coagulopathic, I would consider the anticoagulation. I would hesitate to say that we could do this based on the D-dimer level alone.
So one of the things that comes up is anticoagulation and the risk of hemorrhagic stroke. Tell us about COVID-19 and the increased risk of hemorrhagic stroke. Have you seen any data there? Does it make you more nervous about anticoagulating someone due to a vasculitis type situation?
I think I don't know any better than any other people would say this, but from very early on, for whatever reason, this was raised. Everybody, when literally around the time that we saw our very first case, I remember a lot of our colleagues were worried about intracranial hemorrhage, and is hemorrhage going to be an issue? And this was triggered by this consideration of, as you mentioned, Tom, as neuroinvasive potential. And then from a vasculitic standpoint, that may be more of an issue. I don't know if it's really borne out. I mean, I don't know, if we had proper numbers in terms of the numbers of cases and diagnoses and imaging, whether epidemiologically we would actually see that there's an increase of hemorrhage. We may have an increase of hemorrhage because of hemorrhagic transformation of larger ischemic strokes, but I don't know necessarily that the hemorrhage story is as strong as we expected it to be.
Have you seen any use of TEG assays in patients with LVO strokes?
Yeah, I've heard of it. We haven't used it. So, okay. And I think, it's reasonable to use what you have. But, that's obviously what everybody's doing is empirically trying different approaches at this stage. I think as I mentioned, the greatest impact is unfortunately not in reversing the COVID positive strokes because these are very severely ill patients, but it's in but specifically in terms of the impact on stroke and what we do normally. And I think we have to be very careful, much as we tell patients not to, that we have to, they have to not hesitate in coming to hospital. We should not hesitate as providers in terms of doing what we normally do,
One of the images you showed on MRI looked very herpes-like with bitemporal involvement. What have you seen in terms of, say, lobar hemorrhages, patients that come in that appears COVID-related that are not hypertensive and are non-amyloid patients?
Not much. We haven't seen much of it, So we have not seen much in terms of the immune or encephalitic presentation. I think we've seen one or two cases, but that's been very, very few. We've seen a lot more stroke cases and strokes of various kinds. But the problem has been, once again, disentangling the comorbidities, understanding, that you're not just looking at somebody that has, amyloid angiopathy coming from the nursing home, who happened to be exposed to COVID and then has a bleed, and that's why the focus on young stroke is important, because those alternative etiologies and comorbidities are simply just not as common, so it's a little easier to sort through those things. But you have to keep in mind, that the comorbidities, even in the younger age group, include, are important. Obesity, diabetes and hypertension in those younger patients are also more common.
Right. Knowing that you often put on your hat as the president of SBIN these days, what are your thoughts about the fact that out of Shanghai recently, it was reported that there was up to a 50% drop in the thrombectomy numbers over the last couple months compared to last year? Are you concerned about a drop in thrombectomies throughout the U.S. in this situation?
Yes, very much so. So, I mean, I don't believe that strokes unrelated to COVID have disappeared. They're occurring at the same frequency as they always have, and I have a lot of concern about the fact that people cannot do their own imaging at home. We don't have diagnostic confirmation of what these people are having, and individuals are having. They may be having mild symptoms related to a large vessel occlusion, and they may actually have strokes that are seen at a later stage on imaging. Just because they're mild doesn't mean that they stay mild in terms of symptomatology or deficits. And I am very concerned about the fact that the numbers are so radically diminished. I don't think it reflects the true situation in terms of the biology of stroke or the epidemiology of stroke. Stroke hasn't disappeared. And I think that we are gradually entering a phase where our comfort with handling COVID is increasing, and those numbers will probably go up.
A question related to the China experience again. The groups out of both Shanghai and Wuhan suggested that the hub-spoke model really needs to be tightened up. And our communication and ability to identify LVO stroke at the spoke hospitals, which are now very stressed and very taxed, is potentially a problem. Do you think that there's a role? We have now technologies like Rapid, like Viz, for example, that are being implemented throughout spoke and hub models. I don't think they've made it as far as China yet. But do you think there should be a call to action to develop new technologies and move these existing technologies forward to better define LVOs in a spoke and hub model?
Yeah, I mean, I think that with technologies of various kinds and technological advancements, we have been forced, as I've said, we've been catapulted into a new age, and hopefully a completely irreversible chapter in medicine, in the sense of, if you think about it from a documentation standpoint, from a regulatory standpoint, what we saw in California was the combination of EMTALA rules were relaxed, credentialing at hospitals were relaxed, licensure across state lines were relaxed, and HIPAA was relaxed, so that somebody could call up from Iowa from a neuro ICU or another location, and on FaceTime, if need be, seek a neurological consultation for stroke or other reasons. And that could be actually approved for by CMS. So using the technology to provide the best care we can has sort of become immediately went into place, implemented as the way we should deliver care. So along those lines, I would argue, why shouldn't we be using whatever we have available that can accelerate and facilitate care wherever those patients wind up? As you know, Tom, patients don't all decide to live right next to their closest stroke center. Patients live in all kinds of locations, and nobody can predict who's going to have a stroke at any point in time.
Right.
And I think going forward, yes, there should be a call to arms to use whatever technologies will help us improve the outcome of stroke patients, and also make our lives easier rather than dealing with the bureaucracy and administrative tape that exists.
There's a question about transesophageal echoes. Are you able to get transesophageal echoes as easily at UCLA previously in this era of COVID-19? And does it really affect our thinking when we should get one and when not to?
Yeah, initially they were banned. So initially we had no ability to get TEEs, and that recently changed. I've rotated through the inpatient service a few times now during the whole COVID pandemic when it's hit here in Los Angeles. Initially, the answer was there was absolutely almost no reason you can get a TEE. You could beg and it wouldn't happen. That changed. We are able to get TEEs now, but it's still being used sparingly. And how does it impact what we do? We don't know yet. In terms of what will, and I think that this is important to understand in terms of systematic evaluation from a registry standpoint, in terms of a lot of the tools that we normally use to figure out how it impacts stroke care. So keeping that in mind, I think probably the most instrumental, useful, productive studies that could be done at present are not necessarily to look at COVID-19. Actually, what I would look at is how the use of various technologies such as telemedicine, automated imaging pipelines from different locations, as you've alluded to, Tom, the use of different diagnostic testing has impacted stroke patient treatment and outcomes in general from a stroke standpoint, because that will be very useful to figure out how valuable these tools are going forward.
Question about CSF studies. Is there any role or evidence that looking at CSF antibodies or levels, viral levels, for example, of COVID may actually change our management of these patients? Should we be doing more lumbar punctures on our patients coming in with strokes?
I don't know, but it's a great question, and we have an IRB to look and a study to specifically look at that with Paul Vespa and Manny Blanco and the neuro ICU to look at the CSF of such patients.
Another question came up. Have you seen patients that come in looking like an actual LVO patient that has COVID but actually wasn't having a stroke?
As a mimic that didn't have an LVO, you mean?
But yes, correct, but clearly had cortical symptoms that really look like an LVO. No, we've seen, I've seen cortical manifestations that were associated with intracranial stenosis, as well as LVO in COVID positive patients. And there have, as mentioned, been encephalitides reported and anecdotes of this where they may present with cortical symptoms. But I don't think either we or others have seen a sort of a long case series of stroke of LVO mimics per se. So knowing that there's still a lot we don't know about how COVID affects stroke presentations, at UCLA, as the director of the UCLA Comprehensive Program, what is your protocol for doing emergent vascular imaging, say with CTA or MRA, on patients that come in with stroke symptoms? Do you have a clear protocol?
This changed a little bit. As you know, we've been doing MRI for decades at UCLA, and we used to go MRI first for everybody, and then adapted to whatever is available first, whether if there's a delay in MRI versus CT. When this earliest case that we had at UCLA that was reported by Puria highlighted this issue that we ran ahead with to MRI, we rushed ahead, and then wound up with the very difficult decision about, was that the right thing to do? This was in a patient that had recently been extubated. The only reason we would re-intubate the patient would be to go to thrombectomy, which was the plan. We went to MRI to get better definition from a tissue standpoint as to what was going on. And it turned out that in the end, the MRI findings were extremely valuable in deciding not to go forward because the MRI revealed features that probably would not have been revealed on CT. And we may have gone forward with a futile thrombectomy based on CT than with MRI. That being said, we took a giant step back at that point and started to think about, all right, is this really what we want to be doing with every potential COVID stroke patient or stroke patient during the COVID pandemic, and going to MRI routinely in everybody? Because if you have to decontaminate it, the frequency, this is not social distancing. This is imaging distancing in terms of, the number of people you can get into the magnet in a 24-hour period with 3-hour cleans in between is going to decrease drastically, and it's not that you don't have to clean the CT scanner. It's just that it's, one is a little faster and easier.
Question about aspirin. At UCLA, do you know if they are giving aspirin to all of the COVID patients, even if they're asymptomatic?
No, I mean, I don't know that offhand. I wouldn't be against it. It's just that I don't know, and nor would I suggest that it has, I would not suggest that it has a miraculous effect on, a particular mechanism, ACE2 or otherwise, from a microvascular standpoint.
You mentioned surge planning before at UCLA and the importance of maintaining your resources at the hub hospital there. Are you talking to your spoke hospitals about futile transfers, or are you giving them any new instructions in this era of COVID-19? Yeah,
that has been a very interesting issue in terms of stroke systems of care, because one of the first things we did is we took down our one call policies, our red blanket policies, where there would be no steps required in a transfer of a patient in our system, and subsequently we have reinstated those policies. But there was a lot of issues that came up in terms of how we should treat stroke within a region across not just hub and spoke, but across different networks. And there's a lot of complexity in that in terms of, about, how does a region, maximize resources and work collectively to treat stroke. Those are things that we don't normally do. I mean, normally, as you know, Tom, we work within our own individual systems, our own hospitals, our own networks that kind of overlay each other. But the public health, the overwhelming public health impact of this pandemic brings these issues to the front, and now during the sort of the reopening phase, or we are yet to reopen, but during this phase that we anticipate, there are a lot of issues, not just in terms of acute stroke care, but places will tell you that that from an interventional standpoint, they have backlogs of hundreds of cases and thousands of cases, and it's an open question to those. Everybody doesn't just wait in line. They may seek care elsewhere and in various combinations, and so our delivery of care from a stroke standpoint has really been tossed up in the air in many ways.
And I think this is going to be the source of many other WebExes here and discussions at SVIN, et cetera. Two last questions just to finish up. Number one, as kind of a leader in MRI imaging worldwide, I know that you're doing a lot of MRI imaging on COVID. What have you seen on the MRI scans of these patients that's unique to COVID? Is there anything that you're seeing that seems to be COVID specific that we should know about, you'd like to share with us?
I wouldn't say MRI COVID specific findings on MRI. I mean, unless you're talking about the examples that that you've suggested in terms of the immune encephalitis features. But if you want to consider or define it as a feature, extensive thrombosis, large, not just a large vessel occlusion that, with a clot that winds up at the M1 to M2 bifurcation, but large volumes of clot that extend along the course of one or two segments of cerebral circulation. These very dramatic cases. I don't know if I'd say that those are MRI manifestations, but there's things that we do see on, from an MRI standpoint.
And the last question we just have time for here, if you could just wax philosophical for a second, do you think COVID-19 is going to change neurologic care long-term in any ways? And do you have any closing comments that you'd like to share with us?
Yes. I mean, I think it will not just change neurological care, it will change all of medicine. It'll change even beyond that, the way we think about public health. I would hope it does. In terms of the specific role of neurologists, I think we, as a subset of this theme and within public health and all of medicine, we have to think about what's most efficient in terms of delivery of care, in terms of, how do we provide care to the maximum number of patients in the most facilitated, accelerated, and efficient method possible. And I would argue that we have a lot of tools, telemedicine. It's a lot faster to connect with a patient, as across the distance than running there yourself. I think from an interventional standpoint, I've been saying this for a while, but maybe it's still a few years off, but the more we have the ability to do things remotely and robotically, the better. So there are a lot of different technologies that'll develop, even if it's as simple as the rapid communication via webinars and other facets. I think I wouldn't underplay that. The impact in terms of medical education is going to be profound.
Well, our time is up today, David. We'd love to thank you for your leadership and your great insight here, and we look forward to updates coming from you and the UCLA group in the near future, and certainly from SVIN. And we'd like to thank all of our audience for your participation with us today. Thank you very much.
Thank you so much, and thank you, everybody.